Hello, everyone. This is Dr. Mike Cho, a physical therapist. And yes, I am here at Family Medical Clinic. We are going to be interviewing Miss Deb Leggett, wherein she's going to be talking about how to manage your diabetes. We'll be back in a few seconds, okay? Hello, everyone. We are back here at Family Medical Clinic here in Jackson, Tennessee. Again, if you're watching live, comment live. Watching on replay, comment replay. And I don't know if you can hear us. Type in you can hear us. If you can hear us, that's great because we're just setting this up. We're just moving, doing this camera and a little thing. But yeah, I'm here with Miss Deb Leggett. She's a nurse practitioner, and she's like an advanced
diabetes management.
There you go, advanced diabetes management expert, whatever you call that. But I just want to ask her, hey, I'm diabetic myself. It's free consultation for me, right? So I'm diabetic myself, and I want to bring her here in our group, Geriatric group, the Alzheimer's and Dementia Support Group, and the different people who's been following us. And I want to ask her who she is, obviously, what does she do, what qualifies her to be an educator or a diabetes expert. And of course, how we can manage our own blood sugar and everything. So, Ms. Deb, could you please tell us who you are again?
Yes. My name is Deborah Legget. I'm a family nurse practitioner. I've been in Jackson about 7.5 years. And over the course of the last 7 years or so, I've been seeing a lot of diabetes patients, a lot of diabetics. And I just wanted to have that confidence that I needed to take care of the patient and have more confidence as I'm adjusting their medications. So as I was researching, I realized that I needed to get my board certification in advanced diabetes management. For one thing, there's not enough people in this area who do this type of thing. There's a very small percentage of endocrinologists, so there's a long wait list for diabetics to see an endocrinologist. So we need advanced diabetic experts that can help patients. So I've just gained my board certification in advanced diabetes management. Again, like I said, I'm a nurse practitioner. And what that entails me to do is make adjustments to their medications and just feel more confident in knowing personally for myself that I'm giving the best care possible to the patient.
There you go. Well, first, when you go to a nurse practitioner or a doctor or a physician or a therapist, you need to find, who is an expert on that specific condition. There are like a lot of general practitioners, don't get me wrong, but it's just like me. For example, I have heart issues. I can go to a GP, but of course I want to go to a expert in cardiology. And same thing with diabetes. You got to go to an expert who knows what they're doing. Of course, everybody knows the basics, but let's ask Miss Deb, what is diabetes? What is diabetes, Miss Deb?
Well, diabetes is the inability of your pancreas to do its job. There are two specific types of diabetes that we look at, type 1, type 2. Type 1 is an autoimmune disease that most people develop in childhood, in their younger years, where that the pancreas no longer secretes insulin. And that's a total different type of diabetes. One of the biggest epidemics we have is type 2 diabetes, which is most likely due to our eating habits, obesity, things like that.
Why are you looking at me when you said obesity?
No, I'm not. No, I've struggled with my weight my entire life, so I know exactly how hard that is. And it's not easy. Like years ago, we used to talk about how to take care of diabetics, and it was more like a punishment. The patient felt punished when they come in to see their provider. And now we're taking an approach where you got to meet the patient where they are. Where are they in their journey to get better? Where are they on their education level? And we want to meet them where they are and start from there and try to develop a plan. And we don't want to seem like we're criticizing them, because that's not going to get your patient to
That's
do
true.
what you need them to do. You want to gain their support and gain their confidence, and let them know why they need to make certain changes. And some people, they just are not going to eat better. So if they're not going to eat better and they can't make those changes, then we need to give them the proper medication so that we keep the blood sugar levels down, so that the vascular complications to the eyes, the kidneys, the blood vessels, those things don't happen. So, you just got to start with the patient and just let them know that you're there to help them, not to discourage them, not to, complain about their weight, complain about their blood sugars. Help them, give them the tools that they needed. And I realized I needed more expertise on continuous blood glucose monitors. I wanted that confidence to be able to say, okay, this is how much insulin this patient needs. And it just done so much for me personally that I know I can give back to the patient.
There you go. I want to go back to, the very first thing that Ms. Deb said, type 1 and type 2. There's two types of diabetes, obviously. One is, the autoimmune. Second is the acquired. So can you progress from type 1 to type 2 or type 2 to type 1? Does that matter? Or is there
no,
if you're type 1, you're always type 1. If you're type 2, you're always type 2?
Yes, but you can reverse type 2, or at least get it under control with proper diet, medication. I mean, that's our goal, is to get the patient to where they don't have the eye complications. Because most of the patients either develop what we call retinopathy of their eyes, or they will develop neuropathy of their feet and legs, which is very painful. You know that. As well as they develop kidney complications, which we call nephropathy. And that's just even worse. They develop kidney failure. So our goal is to get the patient's blood sugar down. And is it a quick process? No. It takes time and commitment from me and from the patient.
So you mentioned about, being a patient advocate. How does one check a patient's sugar levels or the blood glucose level? Can they check it by the blood? You mentioned about the glucose monitor.
Lots of times when a patient's first come in, we may just do a routine urinalysis, a urine specimen, and find that they have sugar or glucose in their urine. And that's usually sometimes the very first indication. So we can do like a finger stick, then we can move on to doing like an A1C. That's a calculation of the blood glucose over the last 3 months. And then once we establish that diabetes diagnosis, it is imperative that we start right then, get that blood sugar down. Normally we would hit them with one medication. Now we're trying to hit them with two, so we can make a dramatic change. And generally, by the time a patient is diagnosed with type 2 diabetes, they've probably been well on their way for 3 to 5 years. So we will get a baseline eye exam on every patient. Yes, we
maybe
send
that's the reason why I'm wearing eyeglasses. Again, if you're watching live, comment live, watching on a replay, comment replay. Ms. Deb, so you mentioned about monitoring the blood glucose. I know she mentioned about the nephropathy. When you have sugar in your urine, on your pee, and because you've got too much sugar, it goes to your urine. So when we check in the urine, we check on the blood sugar on the stick or whatever you're checking. What is the normal level for the urine and for the stick? I mean, is there a difference on it?
Generally, like, we're looking for a blood level less than 100, like a fasting, meaning you've not eaten. We're looking for a fasting blood sugar under 100. Anything between like 100 and 119 is considered like what we call pre-diabetes, borderline diabetes, and anything greater than 120 we consider fasting, again, not eating, as a patient is diabetic. So over the last few years, they've tightened those reins a little bit, where that criteria is getting smaller and smaller.
I bet, because dietary changes is just changing. It's evolving. We live here in the United States. Everybody eat first world food.
Fast food, processed food. I mean, unfortunately it's easier and cheaper to eat unhealthy, than it is healthy. So it's hard to break those habits.
It's so true, so true. So you mentioned about the blood glucose level, the urine checking, or you're checking your blood stick and everything. How you mentioned about this word A1C? What is specifically A1C?
An A1C is
Mhm.
like a 3-month time frame. It's like taking a picture of your blood sugars over
Mhm.
the course of the last 3 months and combining them into one number.
Mm.
And anything greater than 6.5 and above
Mhm.
is considered diabetic.
Mm.
Your normal range is less than 5.5.
Mhm.
So anything 5.5 to 6.4 is considered prediabetes,
Mm.
like borderline
Mm.
diabetes. So, and we used to wait years ago, because I mean, I've been in nursing a long time,
Mhm.
that we would wait until that patient was diabetic. We don't do that anymore. When that
Yep.
patient's levels start coming up to what we call the borderline
Mhm.
pre-diabetes, that's when we start. We do not wait for that patient to go full-blown diabetes. We try to start making those lifestyle changes,
Yep.
medication adjustments, getting them active, getting them healthy, then not wait for the complications to start.
Why are you looking at me when you say active? So.
I know I need to be more active too.
Me too. I was just teaching a class this morning. I was talking about the diabetes in numbers, and I said, well, you got to listen to our interview later, because we're going to be talking about diabetes. So
Yeah.
you mentioned about lifestyle changes. So before we go to the lifestyle changes, I want to ask you about what are the signs and symptoms? What do we need to look at? Are we diabetic or pre-diabetic? Do I pee a lot? Am I hungry all the time? Am I thirsty all the time? What are the signs and symptoms?
Lots of times when you got a child or an adolescent, if they have continually eating all the time, which we know our boys do that. Our boys do that, when they go through the preteen years. But if you got a child that's eating a lot and they're losing weight, that's a number one red flag. If they're putting in a lot of volume and they continue to lose weight, or they're feeling tired all the time, or you notice they're going to the bathroom all the time, excessive going to the restroom, to urinate is a sign. Sometimes they'll have skin infections, like yeast overgrowth. So that's some of the changes. But with type 2, a lot of these people have gained weight over a certain amount of years. A lot of them will complain of severe fatigue, headache, just generally not feeling well, visual disturbances, visual changes, just numerous symptoms. And of course, with type 2, it is hereditary. So if you have family members who have type 2 diabetes, then your chance of getting type 2 diabetes even equals. And then we have a different saga with gestational diabetes, when women are pregnant and they develop diabetes during pregnancy. So that's another complication.
That's so true. That's so true. Like what Miss Deb said. Again, if you're watching live, comment live. Watching a replay, comment replay. I want to like what she said. Look at that. If it's type 1, if they're eating a lot and they're losing weight, that's type 1.
Yes.
If you're type 2 and you're eating and you're hungry all the time and you're thirsty all the time, that's probably type 2. So remember the 4, is it 4 P's or 3 P's? Polydipsia, polyphagia, polyuria, and
you put me on the spot.
I'm sorry. Let's just say 3 P's.
Yes, those will say the 3 P's.
The 3 P's. Polydipsia, you're always thirsty. Okay. Polyphagia, you're always hungry. And polyuria, you're always peeing. Yes. Poly means multiple. Okay. Dipsia means you're always thirsty. Okay. Phagia means you're always hungry. It's like me. And polyuria, uria means you're peeing all the time, because you're drinking all the time and you're peeing all the time. So watch out those signs and symptoms, because it's very important. And if that happens, you need to go to a good nurse practitioner, a good physician to check you. And
don't wait, because those complications can by the time you start showing symptoms, it's been there for a while.
It's already there.
Yeah.
It's like hypertension, right? The hypertension doesn't start immediately. Yes, you can be stressed out and your blood pressure could go up, but that hypertension, it's already been there, slowly going up because of your cholesterol levels, your stress level. And same thing with diabetes. Don't wait to the point that you are always hungry, you're always thirsty, you're always peeing. And what's happening is that you can reach, what do you call that? Diabetic
ketoacidosis.
Ketoacidosis. Yes. We don't want that. See, she's the expert. So
that's extremely dangerous, and it can be fatal in a type 1.
And then some diabetic patient, you can smell the sugar in their breath and even in their pee.
Yeah.
Their pee, for example, they don't. Let me turn this off, okay? Just say, for example, they pee and they didn't flush. Some people, their pee gets ants because it's so sugary. And their breath, smells like fruity breath. Am I correct, Miss Deb?
Yes.
She sees this all the time. So, Ms. Deb, so what are the common management? I know you're very busy. What are the common management aside from, you mentioned about lifestyle changes? So,
Well, we look at the patient. Sometimes, depending on the patient's level, we'll either start with an oral agent being by mouth, or we'll start with something by mouth and possibly an injection. And we've come a long way over the last few years. We have once a week injections where patients are not having to inject themselves
I remember
every
my mom
day.
doing that. Yeah.
We have continuous monitors. Like I've got one on my arm now just to kind of.
Are you diabetic too?
No, but I'm learning how to teach my patients how to download these, and how better way than to be a subject myself. But I made some lifestyle changes probably about 6-7 years ago because I had diabetes right on the edge. So I knew I had to. I mean, it's it has no boundaries. It loves everybody. But I thought this is a good way. Our rep came and she's like, let's show you how to, let you be the patient.
That's
I
true.
just thought it was wonderful. I see what they go through. I see their struggle. But this thing right here, these continuous glucose monitors are wonderful.
I bet.
And your provider can actually go in and download those and look at those once a month and help you with your blood sugars. So we've got software now that we can use on our phone, our phones, where we can see and we scan it and it tells us what our sugar is, not without poking the finger. That's what people's thing is. I'm not giving myself a shot. I'm not poking my finger. But now that we have weekly shots, we have oral medications that we may not ever have to put somebody on a shot. Patients are just doing so much better because I've been a nurse a long time. Years ago, all we had was 1 or 2 insulins, and that was it.
Yeah.
Now it's like it's this whole conglomerate of good drugs that we can use to treat this horrible disease.
Well, so we mentioned about the monitoring and everything. So does insurance cover it, or you got to pay out of pocket?
Most of them cover really well. It just depends on the insurance. Most commercial insurances, you've just got to have a diabetes diagnosis. Medicare, you generally have to be on a couple of injections a day, which most are. And then our TennCare population, we can get those covered as well.
Wow.
Yeah.
So
and there are some patient assistance programs out there, and there's different companies, different options. It depends on which monitor you're looking at, whether it goes to the pharmacy, a DME, or a specialty company.
I have several patients who have that monitoring device, and I'm like, what? And then they'll just put their phone. And I was like, see, I got all my readings here, Michael. Well, the question is it normal?
Yeah. And they can go in and download that, and the provider can go in and look at their month. And what we're looking at is the percentage of time and range. And we want at least 70% of their time within 120, between 100 and 180. So blood sugar wise, and we want to make sure that they're meeting that, and we also want to make sure they're not having low blood sugar. If they're because that can be dangerous as well. And there's a percentage of time that we want them to be under that target. If they're over that target, then that means I need to make a medication adjustment. And it's very good to help guide the patient. And I've seen that it helps the patient. If you don't see it, you don't know it. But if you see it, you will be like, I might not eat that cookie.
Yeah, it's very important. You got that biofeedback or that visual feedback, not just hearing from your provider, but just seeing it. Oh, this is my number for today. Not just because you go to the doctor every 3 months or 6 months and you forget it after a month, but if you see it right there and then in your computer, on your cell phone, everybody's in a cell phone nowadays, right? Oh, I'll be more conscious about it. It was like me this morning. I checked my blood pressure was so high, and I had to take my medication. So I like what she was talking about, medication management and adjustment, because your body changes during the day. What you're eating during the day changes. So it's very important that you, of course, as a provider, they're educating you, and you as a patient, you need to learn how to adjust and adapt your medication itself. Because if your sugar is too high and you're taking the regular level of this medication, you need to learn and talk to your doctor or nurse practitioner to adjust it too.
Yeah, so you want the patient to
Mhm.
be able to just make that adjustment.
Mm.
Not all patients are able to do that, but the majority of your
Mm.
patients are. That we want them to take ownership in their disease
Mm.
and get them on board and get them to feeling
There you
better.
go.
Yeah,
There you go.
and if you
That's the
see
word
that
there.
blood sugar, you're gonna act on it. If it's like stored or you're not seeing it,
Mm.
it makes a world of
That's so
difference.
true. That's so true. I like what you said about ownership. It's not that you're embracing the sickness. It's not that you're embracing the victim mentality, but what she's talking about is like you're owning it and being responsible for your own health.
And
And
taking
that's
charge of your life. Yeah.
hmm it's very important that we take care, because if you get better, not just because their insurance wants us to make you feel better, right? But if you get better, you're doing this not just for yourself, they're doing it also for your family,
Mhm.
right? You're doing it for the future of your kids, the grandkids, or whoever, because diabetes is actually one of the highest, killer
Yes.
nowadays. Of course, number one is heart attack and everything like that, but it's all connected. Blood sugar is high, blood pressure is high too. So, Ms. Deb, I know you're so very busy. So, what are the different medications? And then after this, we're done. So, I mean, we're not going to prescribe. We're not your primary doctor.
Yeah.
But what are the different medications that you normally, recommend? Do we have injections immediately? Do we take, oral metformin or glimepiride, glipizide? I mean, what are those?
There are a lot of oral medications that you can start off with, like metformin,
Mhm.
glipizide, glyburide, Actos. There's also injections like Ozempic,
Mhm.
Saxenda, um, Victoza that you
Mhm.
can do once a week. There's Bydureon,
Mhm.
there's Trulicity,
Mhm.
there's Tresiba, there's
Mhm.
Levemir. There's all kinds of medications that we
Mhm.
can start off with. But ultimately, our goal is to get your A1C, depending on your age, under
Mhm.
7. Now, if
Mhm.
you're in the geriatric population of 80s and 90s, which I'm
Geriatric.
doing a whole lot more geriatric with this dude, and I've had to learn, I had a conversation with a family the other day. Yes, grandmother is 94 and she is now diabetic, but her A1C for her age is okay because the medications are more of a risk when you're
Mm.
94.
Mm.
So, we kind of have to take the patient's age and keep that in mind. And our target is just a little bit more lax.
There you go.
Yeah.
Did you hear that? It's very important that you go to a practitioner that knows what they're doing depending upon their age. Why? Because the normal for is this young person's age cannot be the same normal range for the other geriatric population. It's
No, and
very
they're not
important.
as active,
Mhm.
so their medication needs are not going to be as much.
If their sugar is low and then they're not doing anything, that's fine. Okay. If it's too high, obviously, and then they're hyperactive, they're walking all the time, they're like wandering, let them be something like that. So, like what Miss
Yeah.
Deb earlier said, you gotta go into their world, meet at their level. In that way, you can.
That was the biggest thing I got from this
Mhm.
entire process was that I remember years ago, it was like every diabetic was punished. They
Mm.
hated to go to the doctor
I know.
because they were going to be scolded about their sugars. I do not do that.
Mm.
They taught us you meet that patient where they are, and I loved that philosophy. Meet the patient where they are, treat them as an individual. Don't treat me like I treat you.
Mhm.
Same vice versa.
Mhm.
You're a man, I'm a woman.
Mhm.
We all have different needs. My age, your age, everybody's. You just take that patient and develop an individualized plan.
Mm.
And that's where we're going. It's individualized. And I'm just so happy to be able to do this.
There you go.
Yesterday I had 2 really complex diabetics. And I was like, whoo, sometimes I feel like I'm over my head, but then I'm like, okay, take a deep breath. And then I just sit down and, and just try to figure out a plan
There
for
you
them.
go.
But it's not easy.
I bet, yeah.
None of this is easy.
Every day
takes,
it's different for them.
Yeah.
Yeah. It's not just okay. You got, you go to dialysis 3 days a week or 3 times a week.
And we don't want to do that.
Yeah,
That's my
Mhm.
background, 20 something years of dialysis, and it's my goal to keep you who have high blood pressure and
Mm.
diabetes. Those are the two main killers of your kidneys,
Mm.
hypertension and diabetes. And if you have both and you don't control them, you will be on dialysis.
I know. Why
It's
are you
just
looking at
it's
me?
just a matter of it's just
My
a
dad-
matter of when. I
The
mean,
mom and dad went through that, so it's so
Oh,
hard.
yes.
So hard.
Yes,
So
it
I
is.
feel you. Well, anyway, Miss Deb, thank you very much for
Well,
your
thank
time.
you.
Any last parting wisdom for for our geriatric population? Where they can find you and everything like that.
I'm located in Jackson, Tennessee.
Mhm.
I'm at 1022 Greystone Square. Our number is 731-300-2001. And I encourage you, if you feel like you are a diabetic or could be developing diabetes, please go see your provider and please let them check you, because even if you're 55, 60 and you live another 20 years, 30 years, we want you to be healthy, because with diabetes, you age much faster when it's very uncontrolled. And we have so many medications that are so much easier to take care of diabetes now.
That is so true. Again, thank you very much, Ms. Deb. Appreciate
you.
you. Thank you for your knowledge, for stepping up, for being, a better provider for not just for yourself, but also for your community. So again, thank you very much.
Thank you.
But before I let you go, always remember the word FAST, FAST, letter F. Find people that will bring out the best in you, because you are the average of the 5 people you hang out with. So who are you hanging out with? Are you hanging out with people who are diabetic? Guess what? You're going to be diabetic too, because you're going to eating the same habit, right? Hang out with people who are healthy. They're finding lifestyle changes. You're going to be healthy. You're going to have to be adjust your lifestyle to find people. Also find practitioners and providers who are actually going to bring out the best in you. And this is where Miss Deb comes in, Family Medical Clinic. So letter F. That's letter F. Find people. Find a practitioner that will take care of you. Next letter is letter A. Take action. All this stuff that we're doing is not going to do me good. It's not even going to do Miss Deb good if you don't take action. Okay. This one that we're doing, we don't get paid. I don't get paid. She doesn't pay me. I pay her. But you got to take action. Go to a practitioner. Go to Family Medical Clinic. Have your blood sugar checked. Go to a wellness check or whatever they call it. Take action. Because this is going to be you. Nobody's going to do this for you. Yes, your spouse can take you there, but only you can change your condition. Okay. Well, of course, the medication, the doctors, but only your own action will change you. Okay. Next letter is letter S. Share and subscribe. The more shares, the better. Okay. Share Family Medical Clinic's website, Facebook page. The more shares, the better. Sounds cheesy, but it is. It may be not be applicable to you. You're not diabetic right now, or I'm not saying you're going to be. But what I'm saying is that it could be applicable to someone else, and they can learn from this topic that we're talking about. And last but not least is letter T. Is teach it. Why? Because when you hear it, you forget. When you see it, you remember. But when you're actually teaching it, you're actually understanding it more. And that's what Miss Deb is doing. She's teaching us how to understand diabetes and how to manage it properly. Again, thank you very much, Miss Deb. Appreciate you. Any last parting wisdom? You're good?
I'm good.
All right.
Bye-bye.
Again, bye. Thank you.